Ciarán Devan, the new Chairman of the Health Executive, the HSE. Thank you. On behalf of the committee, I would like to welcome you to the meeting and to congratulate you on your appointment and wish you the best of luck in the future. We have great expectations of the new board. Mr Devan will outline his experience and strategic vision for his new role as the new chairman of the HSE, particularly in light of the challenges we face in the implementation of Sláintecare. I also note that the new board of the HSE held its first meeting last Friday. I wish to draw your attention to the fact, by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person, persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise that any opening statements that you make to the committee will be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask you, Mr Devan, to make your opening statement? Thank you.
First of all, thank you to the chairperson and to members of the committee for inviting me here in my first full week as the chair of the board of the Health Service Executive. And if I could introduce Mr Jim O'Sullivan, who joins me today, who we've appointed as the secretary to the board. The Minister of Health signed the commencement order for the Health Service Executive Governance Act last week and came to the first meeting. I think the establishment of the independent board to oversee the HSE is a really important step in improving the governance of the health service, and it's one of the key recommendations, of course, from the Sláintecare report, which is the first of two reasons I feel very privileged to be with you today. Myself and my fellow board members, I think our commitment to you is that we will make as good a contribution as we possibly can to achieve your expectations as a committee as expressed in that report. And the second reason I feel privileged to be here is that in deciding to apply, of course, I read the Sláintecare report, and it was one of those documents that as you turn the pages, you get more and more excited and more impressed. And I'm not the only one on the board who has said that the plan and the cross-party support that it's had was a large part of why I went for the role, and I think that's very important and very commendable. From my perspective, if I can just focus on just a few things, so I have a chance to take questions. Your invitation referred to insight on my own experience and vision for the role. So a little bit of background on myself and why I did decide to answer the call to take on the role for what is one of the most important state boards, in some ways maybe the most important state board in the country, and it's never far from public discourse. I was educated at Gaelge in Cloistewer in Parnell Square, for those of you who know it, and as a chemical engineer in UCD, what is now the Department of the Taoiseach. And my work today has largely been in the UK, but sometime in the United States and sometimes in continental Europe. And my early career was in chemicals and life sciences, sometime in management consulting, and most of what I did there was running large change programs in multinational organisations. At the moment, I'm Chief Executive of the British Council and have been since 2015, and there I focused on aligning the Council behind the themes in education and culture which are important to the UK as a country, the international side of that, and strengthening the organisation as a network of 115 country operations. It's probably the bit in the middle which is more directly aligned with the HSE. From 2007, I was the Chief Executive of Macmillan Cancer Support, where I helped the organisation reshape how cancer services are done across the UK and the four nations of the UK, both in its own and in collaboration with other organisations. And as a result of that, Macmillan is consistently seen as the public's most respected charity. Some of what we did was about new models of care, some was around using data to improve measurement and outcomes, and some was around focusing on patient experience. In terms of governance, I held non-executive roles on a number of boards, from small charities through to the board of NHS England, which commissions healthcare for the population of England. And there are many differences as well as many similarities between the HSE and NHS England. But both are organisations and boards which are ultimately accountable for spending taxpayers' money to deliver the best possible healthcare for the available money for the population of the jurisdiction. So I hope my experience, I believe my experience to date puts me in a good position to lead the board in its transformational journey, really, around the ambitions of Sláintecare, at the same time as holding the executive to account for delivering the current plan. In doing so, we have to have the credibility to make the changes needed to have a health service which will continue to serve the public into the future. We did have our first formal board meeting on Friday, but we had got together a number of times previously, and I'm very pleased with the calibre of those who the Minister and the Department have appointed to the board of the HSE, and those members, and like myself, who believe in public service and public health. I think driving that ambition, make sure we have a truly world-class health system that we can be proud of, is something that we are united behind. There are 10 other members currently, with one additional member to join. We are varied, we're different, we have different competencies, we have clinical expertise, governance expertise, patient advocacy, change management, financial management, which I think now my role is to bring that together into one properly functioning board, holding people to account at the same time as driving the strategic direction. I was also very pleased with the appointment of Mr Paul Reid as Chief Executive, and I look forward to working with him and his executive colleagues on the shared ambition. The cross-party political support which was behind Sláintecare does give us a great opportunity. I think a once-in-a-generation opportunity to build a health service which is forward-looking. And I think as a board we have a few things to do. One is to exploit that momentum for change in the best possible way. We also have to ensure that we have the right systems, the right controls in place to ensure financial stability, financial predictability for the HSE, and make sure that we support the executive to ensure that we create the public confidence, which will then, through our financial management, which will then allow us to seek the further investment for the implementation of other aspects of Sláintecare. I have had a chance to discuss our short-term and long-term priorities with officials, with ministers, with board members, and they really come down to 4 things. One is effective performance management and accountability for the HSE. Second one is building that public trust and confidence in the HSE and the health service. Out of that comes making sure that the HSE's full support is behind the implementation of the healthcare reform programme and Sláintecare implementation plan in particular, and support the leadership and staff of the HSE to improve outcomes for the public, and retaining that focus on outcomes. The last thing I really want to say, I think, is there is a great deal to be proud of. In particular, the huge progress which has been made on outcomes, and I particularly point to life expectancy going forward. Since 1990, life expectancy in Ireland has gone up by just under 7 years, and that equates to, in an average year, life expectancy goes up 3 months. If you take a typical day, it goes up 6 hours. So on average, since 1990, every day of every year, life expectancy of the average citizen has gone up by 3 months, which is truly astonishing. It's one of the fastest rates of improvement of any developed economy. There is a lot more to be done, which I'm sure we'll touch on, but on my own behalf and behalf of the board, I'll be looking forward to working with the wide range of stakeholders involved, but including yourselves, going forward to do the job that I think when you made that recommendation in Sláintecare you expected of us. So, Margaret.
Thank you very much, Mr. Dolan. We're now going to give our members an opportunity to engage with you. So our first member is Deputy Stephen Donnelly. And just for those who came in later than our private session, we have a meeting with the Minister at 11:15 in relation to a select committee meeting in relation to the cervical check tribunal bill, so to be conscious of that when you're making your contributions. Deputy Donnelly.
We'll do our very best, Chair, as always. Mr Devan, thank you very much for appearing today. Mr Sullivan, thank you for your time, and the very best of luck. It's the HSE is one of the most, if not the most important and complex organisation in the country, and certainly having the board back is very welcome. I think the abolition of the board was a serious mistake some years back, and it's good to see it back in place. Certainly the health system has suffered without having a board in place. Could I ask, on three of the main roles of any corporate board, particularly of an organisation of this scale and complexity, one is the development of strategy. In a normal corporate world, the board is actually responsible for developing strategy. The second is accountability of the executive team, both in terms of holding them to account, sanctions, removing them when necessary, or indeed rewarding them through remuneration and other ways. Can I ask your understanding of this board, because it arguably is a bit different. Do you believe you have a role in setting strategy? And when it comes to holding the executive team to account, presumably you do believe that is one of your roles, and do you believe that your powers extend to tabling sanctions if necessary, up to and including removing the Director General or removing other members of the executive team? And indeed, on the flip side, do you have any powers, or do you see that you have any authority in terms of reward, in terms of whatever rewards might be deemed appropriate by the board at an executive, a DG level or an executive team level?
Thank you. I do believe we have a role in determining strategy. I think it's in collaboration. You know, we do operate in an ecosystem, and that the policy side of strategy, which is the purview of the department, informs how we do what we do. That needs to be a dialogue, and finding the best way to implement an agreed overarching vision and strategy, there are choices to be made in that. So if strategy is about making choices about what to do when and what to do later, and maybe what not to do at all, then absolutely we have to have a role in that. Do I believe that we do that in isolation? Absolutely not. It's a public sector board. We do it in an overall policy context, and we have to make sure that we work with the other organisations in the ecosystem as well. So no, we shouldn't be isolationist or doing it on our own, but absolutely we have to be engaged in that dialogue. And if you believe that good dialogue leads to good strategy, then I think that's important. Accountability, I think there's an additional bit as well as the reward and the carrot and the stick, I think, which is having the right processes which create the clarity so that people know what they're being held accountable for, and that accountability is for the whole range of things. It's not somebody's accountable for the money and somebody else for meeting the access targets. No, it has to be collective because they're so intertwined. So I think there's I absolutely see us as being accountable for making sure that that cascade of accountability is in place and the clarity that is necessary. And then where people are performing, we need to recognise that, reward that, which doesn't have to be financial, but it can be about opportunity and engagement and promotion and so on. And equally, if somebody's not performing, absolutely, we need to have the conversation, say, look, you might be better off over here or elsewhere.
And so at an executive level, do you feel that the board has the authority, if necessary, yes, to remove a Director General from their post if the board believes them to not performing?
Yes, if we felt that the performance of the organisation and the health of the population was at risk because of the performance of any individual, then absolutely as a board we would be doing that. Again, I'm not sure I'd want to do it in isolation, but sure. We would face up to that.
Okay, I'll ask my other questions in just one go, because obviously we're stretched for time. You might come back from them. I note in your statement you talk about priorities of the board which are all fine, but what I don't see in your priorities are issues around access for patients and quality. The reality now is people are waiting 3, 4, 5 years just to see a consultant. So access in some areas in Ireland is worse than it is in parts of Africa. It's the worst in the OECD. We have the lowest number of consultants per capita anywhere in the OECD. We have the second lowest number of hospital beds anywhere in the OECD. We've reached a complete crisis. Consultants are talking about the hospital system being on fire. There is a crisis in lack of access for children, for men, for women. And then when you get into the system, there's a narrative that is told that, well, the Irish healthcare system is very difficult to get access to, but once you're in, it's brilliant. Well, bits of it are and bits of it aren't. We have unsafe staffing levels all over the system, and I know Paul Reid's briefing included some of that. Can I ask, as the incoming chair, what your views on to address, well, first of all, would you agree that we have a crisis in terms of access to healthcare? What can be done, what needs to be done in the short term to deal with this 3, 4, 5 year wait that people have? And in terms of addressing some of the quality issues in the system, accepting that some of it is excellent, what would your short-term priorities be for the board? And I'll leave my questions at that. Thanks, Chair.
Thank you. Large question, obviously. Yes, I agree. Access is a problem. For all the reasons you said, it's the metrics, it's what the taxi driver tells you. It's it's well understood, and therefore it is a priority. Short term, I think as a board we'd be saying two things. One is we need to see programmes in place which directly address access issues in particular points. Secondly, we need to see that the models of care are shifting to a model which allows rapid access, rapid discharge, so that the throughput of a system can be changed. Some of that is around staffing levels, some of it's around models of care. It's probably worth saying when we've been talking about setting up board committees, and we've agreed that, and we have allocated board members to 4 committees. Audit and risk, as you would expect. We will have a people and culture committee, which is looking at kind of strategic HR, so more than a kind of a traditional remuneration committee would do, but strategic HR. Quality and safety, looking at everything from the kind of never event space, but also are we delivering the outcomes that we should with the right levels, and a performance and delivery committee which will directly be looking at metrics which will include waiting times, access, as well as are we delivering the number of procedures that we said for the price that we and cost that we said. So we're seeing that the board committee, we'll have those committees, but 2 of them are very specifically focused on a patient-oriented point of view, and the other one on the people and culture is how do we make this the best place to work as well as a place that delivers the best health outcomes.
Okay, thank you. Thanks, Chair.
Thank you, Chair.
Deputy Donnelly and Mr. Devan. Deputy Louise O'Reilly.
Thanks very much, Chair. And good morning to you both. I wish you the very, very best in your role. You refer in the just now, and indeed in response to the question, to the issue of access and the issue of capacity. So what we say, it's 12 years ago that the first recruitment moratorium was introduced in the HSE, and just by way of context, I happened to be a trade union organiser at the time, so we were engaged in an industrial dispute with the HSE with regard to what the government of the day were doing in terms of the moratorium. Now, of course, we feel the effects of that now, and we will continue, I think, to feel that for quite some time. But at the time, we were given to understand that the board had relatively little, if any, involvement in that, and that it wasn't the position of the board to take a view with regard to the moratorium. But from what you're telling me here and the establishment of these committees, it is your intention to be proactive around issues of access, issues of human resources, people and culture, whatever industrial relations, as I would have called it, but whatever the terminology is that you choose to use. It's not traditionally been the role, I think it should be, by the way, but it hasn't traditionally been the role of the HSE board to be very hands-on. Is it your intention that the board will have a proactive role and will, assist with issues around access? Because it's 12 years since the moratorium was first introduced, and the impact of it is still being felt to this day. And at the time, there was a genuine belief among workers that the board should have stepped in, and they didn't.
Yeah. I'm probably not qualified to speak about the time, but I think it is our intention as the board to, at the strategic level, to say, look, we need to be addressing this, and how we support the great staff of the HSE who do great things every day to do even more great things. I think that has to be part of our role. There are other aspects which are not, which are the purview of the department or deeper. But I think as a board we have to be saying, how are we going to deliver the outcomes that the public and this system deserve. So I think we shouldn't be ducking that, I think. And the health systems, certainly from my experience, health systems, you can have structures, you can have policy. It's really a people ecosystem.
They are your best asset.
Yeah. and therefore how people work together, and how the relationships between community organisations and acute organisations, how the relationship works is at least as important as what kind of structural, construct you decide that you want to have. So I think absolutely, any good board needs to be thinking in terms of, the people, the staff, the skills, the, staff shortages, consultant recruitment, pipelines. It has to be part of the what we worry about. Other people again will, be influential in that. But if it's a critical success factor for the delivery of what we're supposed to be delivering, we should be opinionated about it.
Okay, that's welcome. The government, and I will give my view, and I'm not suggesting for a moment that you share it. The government's commitment to Sláinte Care has been fairly weak. The appointment made is very welcome, but the money that's put against it indicates that there's no massive interest in implementing it, notwithstanding the cross-party support for it. Sláinte Care needs to be driven from the very, very top. Otherwise, it's not going to succeed. It's 2 years since it was published, and there hasn't been. There has been no discernible progress with regard to it. But a big part of the Sláinte Care report involves not just a shift to the community, which is really important, but also the elimination of the phasing out, or whatever phraseology you want to put on it, of private care from the public health system. So I am interested in your view of privatisation within our health system, be that as it happens by stealth, or as it happens by government policy via the NTPF, or in the various other ways that we see the public service undermined and chipped away at and hived off into the private sector, which in my opinion does not represent good value for money. But I'm interested in your view of private versus public healthcare, because there is a very clear commitment in Sláinte Care to move away from private involvement in public hospitals and towards public delivery of care.
Thank you. I think the strategy is clear. It says what it says, and on day 3, I'm probably wouldn't want to question that at all. I think if we start with the HSE is a public service, and therefore what are the conditions which we need to make sure that our mission is delivered as well as possible, and what can support that and what can get in the way of that, then how we interact with private providers, whether it's private providers of equipment or pharmaceuticals or clinical services, is a key part of that. So I think the difficulty, certainly again from experience in the past, is when the two get muddled up and you're not clear which it is, and then you get perverse incentives, and then you get, are there, is an operating theatre being competed for within a particular institution? So I think the if there's a longer step and kind of a vision for the end point, what those first steps are, which say what are the things which are getting in the way from delivering great services today, they're the ones I think that we, certainly intuitively, I think we would look at first and say, how do we make best use of this theatre, and what is preventing us doing that? So I would be I'd be starting with the outcome and saying, are we restricting access in the public service, which the taxpayer is paying for by some of the things we do? And I would be starting at that point as well.
But in the case where access is restricted, and of course it is, if you have private care carried out in a public hospital, it necessarily is restricted. So in the case where it is restricted, would you see it as your role to be proactive in ensuring that that moves out? And if it is an impediment, and by the way, I can't envisage any scenario whereby private activity being carried out in a public hospital isn't going to interfere with public access. So let's start from the position that that's happening. We know what's happening, and Sláinte Care says it's going to move out. So presumably you have a view on that.
And I think Sláinte Care strategy is saying that that's what we're going to do, and until the day we're saying we're not going to do it, we're going to do it. And I think that has to be the the reasons you imply. I think we have to make sure that the the 16 billion euro which is being spent of taxpayers' money on is spent as effectively as possible. It's got to be the starting point with everything.
Thank you very much,
And
Deputy
I
O'Reilly.
apologise, I have to leave.
Thank you.
Thank you. And now Deputy Alan Kelly.
Thank you very much, and best of luck.
Thank you.
Or if I was to jest, sorry for your troubles.
Thank you.
You've certainly taken on a very important and significant role. First question, I was a big supporter of bringing back the board. I also lobbied Minister Harris that you be appointed first and work with him as regards to the actual board itself, and in fairness he took on board my views and actually did just that. I know there's one more position to be filled, and there's been a broad discipline of people who have been brought in, which is good spectrum, necessary.
Yeah.
Yourself, as regards consistency of approach, though, we haven't had that for many years. Yeah. Okay, so we need somebody who's committed long term to this. Yeah. Do you envisage yourself being in the position long term?
Yes, subject to ministerial approval. Yeah.
Okay. Very much taken by what you said on page 5 as regards, priorities. Developing and implementing an effective performance management accountability system in the HSE. We saw from the previous DG acting, Mr. Conahan, when he came here in relation to Justin, and just picking one item, so the whole issue of the cervical controversy and what happened, that once the Scully reports had been concluded, which they have now, that there would be a review of what happened internally in the HSE. I presume you would support that?
Yeah, good. I think
Paul Reid has said he will do that too.
Yeah, I think out of every clinical incident, system failure, whatever you want to describe, there should be learning, and so learning and accountability is part of great clinical governance. So one of the reasons we set up the Quality and Safety subcommittee of the board was for exactly that reason. I think if we can do our bit to support a culture of great clinical governance, then learning from the past, but also saying what can we learn from other sectors. Everybody talks about the airline industry. My background's chemicals. We all have experience of dealing with high-risk situations, and we have to bring that in. So yes.
Yeah, because it falls into your second point, developing a plan for building public trust and confidence in the HSE.
Yeah.
One falls into the other.
Yeah, it does, and I think one of the ways I think I see it is if we have good transparency, good open debate on how to make things better. So I'm not talking blame. I'm saying how do we learn, how do we improve, how do we not put people in a position where the wrong things happen. Then public confidence will go up. If we have predictability on our finances, then public confidence and political confidence will go up as well. So everything, Deputy Donnelly mentioned access. That relates to this as well. So our performance ultimately is what will drive the confidence. So it's not really an activity in itself. It's an output of get things right, people will back you. Get things wrong, people will forgive you if you learn the lessons, and they won't forgive you if you don't learn the lessons.
Three other small quick questions, and then I've finished. I'll be very disciplined, Chair, for a change. I put three of these in one. So, people are the biggest asset in the HSE.
Yeah.
Okay. What are we going to do to attract more people? What are we going to do to maintain the people that we have? Second part of it is, what is going to happen as regards to structures underneath the board? I know you have your subcommittees, etc., but what other changes do you propose to bring forward? Because there is structural realignment required, and it's already been brought through on Sláintecare, which I and other members of this committee spent 11 months bringing forward as regards realignment of the HSE across the country, which I'm personally in favour of. I think it needs to be done. And last part of the same, the final question is, how will your position evolve as regards the whole process of board responsibility for budgetary management? They're my three questions. Thanks.
Thank you. I think there's something around communicating the vision of the future and the picture of this high-performing, place-based, integrated care models, HSE of the future, and giving staff the space to move from here to there. I think, again, from the past, I've seen where there's a great vision, but everybody's running so fast just to cope with the day-to-day that that never gets done. So part of it, I think, is making sure we have the structure and the ways of saying, okay, we want to address this issue. Let's make sure people have the time, the resources to think their way to the future, not just have a kind of the picture in the future with no path to it. I think sometimes health organisations are almost too efficient. Everybody's running around the hamster wheel so quickly, just coping with the peaks of demand that there is no space to move. So I think people, particularly health professionals, are very motivated when they can see how the improvement is happening, not just coping with the day-to-day. So I think if we can help with that, that is part of it. I'm very much into integrated care, place-based health care, so that the link between community and acute is very tight, and public health and physical health and mental health, because the real improvements in future don't take place in doing a slightly better unit operation. We do surgery slightly better than we used to. Yeah, that's great, but the real benefit for the future will be how the community links to acute, how we make sure mental health services are in at the right time, how the support package is around, because that's the way you get into the whole prevention integrated side. So I think the community health organisations, the RECOs, that kind of thinking is the hospital groups rather than individual hospitals. That whole thinking, I think, is right and directionally correct. Do I see us as the board having budgetary responsibility? Yeah, absolutely. I think we have to provide the best possible healthcare for the money available, and we can't spend money we don't have. So getting to that kind of financial predictability, so that we can then go back and say, actually, we want to implement the next bit of tranche of Sláintecare, and you can trust us because we said we'd come in here and we came in here, and therefore if we say it's going to be here, it's going to be there. That is a place which we're not at the moment, but we have to get to, because how else would we provide you with reassurance that we will land a very complex system, on the postage stamp we have to land it on if we haven't demonstrated something like
Multi-annual
that.
budgets would be helpful.
Multi-annual budgets would be very helpful.
Now we're going to move to Deputy Durkan.
Thank you, Mr. Chairman. I welcome our guests and thank them for coming before the committee. And at the outset, I would like to wish you well in the job that lies ahead. It's a challenging job. It's a challenging time. I have also been critical of the performance of the HSE since it was first instituted, and I believe the criticism was warranted. I don't believe that we've had a seamless, smooth system in terms of delivery of services to the people, the patients, the people who matter. Notwithstanding the fact that we are in the 4th or 5th highest areas of expenditure within the OECD countries. And we need to get to a situation whereby we can give value for money and we can give effective and efficiency in terms of service. And I think Sláintecare will do that, provided, of course, that we contain it. My concerns have been in the past that the HSE was remote from some of the institutions over which it had control. And in terms of the delivery of services, and similarly, many of the staff throughout the HSE, throughout the regions, and at its centre, were unsure of where they were supposed to be going and what they were supposed to do and who their bosses were and at what stage they should use their initiative and at what stage it might be dangerous to use their initiative. So that's one of my concerns, and I was concerned about it from the very beginning. I was a member of a health board previously, and I believe that the health board was the opposite. Well, the health boards were abolished because there were politicians who were involved in it, and I think it was the wrong thing to do. I think it was a woefully wrong decision, and I think events have since proven that my conclusion was correct. And the exclusion of the politicians at local level took away from the institutions of the health services the support that comes with local politicians and the responsibility that is forced on local politicians by being in a position of authority. So there were two sides to that story. So I think there's an issue there for yourselves. I believe that you can deal with that. What we have now is we have a board for the whole country, and I have my doubts about that. I still got my doubts about that. And the extent to which you can extend your remits to the farthest extremes of your institutions, and the extent to which you can, which your realm extends infinitely right to each and every corner. I think it's going to be hugely important, and I'm not so sure that I know that hasn't happened in the past. Yeah. And I mentioned the first chief executive of the board. I asked the question as to whether or not he thought that the structure now proposed was the appropriate method of delivering the health services to a population of the size of Ireland over having regard to its geographic location, as opposed to comparing with the Greater Manchester area, which was the case at the time. And the last point I want to make is this, that I think we will all give the support that you deserve to try to do the job that has been very, very challenging in recent times. And I'm look, everybody blames everybody else. That's the problem. And that's the nature of the game. I think that we do have a responsibility. If we're spending a lot of money, comparative lot of money, more than many of our competitors across Europe, I think we need to be able to say, well, look, we're at least on par with an average of them. We can't be behind. It's a challenge, and I wish you well in it. And certainly, insofar as I'm concerned, I'm sure all of us here are concerned, we will do our best to help out.
Deputy Durkan, thank you very much.
Thank you, Deputy. I think that kind of, a board or a HSE which is remote from the lived experience of service users and patients, across the whole of the country is very well made. And I think one of the things I think we'll be thinking about is how, when we get this kind of integrated care regionally, locally, how we make sure that engagement with the communities and the public and local stakeholders, including politicians. I think that's absolutely right. And it's part of this kind of, it's the other side of transparency. It's, we have to be able to listen and get the feedback as well as communicate what is going on and what is possible and what isn't possible. And this principle of, subsidiarity is really important in that. I don't think that my vision for the HSE is everything comes up to the centre and then everything goes back down again. It's really about how do we enable the local organisations to work well together to deliver the best possible healthcare locally, as well as making sure it all adds up. So I think that's a point well made. Thank you.
Thank you very much, Mr. Devan. And now we are going to go next to Senator Mullen. Thank you.
Thank you, Catherine, again. You're very welcome. I suppose three areas or three issues I want to ask. First of all, just your own I know you're Sir Kieran Devan in another jurisdiction. I presume the
That
minister.
is true.
I presume the minister doesn't have to call you Sir, and certainly I think Deputy O'Reilly would have problems with it as well. But are you? Forgive my ignorance. Are you full time now in this role? Have you left the British Council?
No, I'm juggling at the moment. What I've said is we're having a new chair arrive in my current organisation, and I was staying beyond Brexit, but of course we don't quite know when Brexit is going to be or if Brexit is going to be, and then the transition will.
But will you and all your board members be full timers?
No, we're not. We're non-executive part time.
Right.
The expectation is 2 days a week in my case.
And obviously you're a very capable man and you've a great CV, and particularly in healthcare and with the NHS and all of that. But do you think a behemoth like the HSE can be effectively chaired and governed by people who are not full-timers?
I do. State boards, the non-executive boards, as they are not populated by full-time people, because we're not trying to be the executive. If we become the executive, then we cause confusion. I am not the chief executive. I have to hold the chief executive to account. Now, there has to be sufficient time in that, and you have my commitment to making sure there is sufficient time for that. And I hope over the last 9 months, when I've been in shadow form, so to speak, have demonstrated that. But what I mustn't do is imagine that I'm second-guessing the chief executive and the executive. Because if we do that, then you end up in an organisation with two competing chief executives, and the clarity which is needed wouldn't be there. Which, when your day job is being a chief executive, of course, you have to learn to sit on your hands and sometimes choose not to say things and not be opinionated when you might privately be opinionated.
Okay. But nonetheless, in your bird's eye view that you have to take, and you have to obviously get accountability from the full-timer, so to speak, would you agree with me that mental health services in particular have been the poor relation when it comes to spending in recent years? I'm thinking about the fact that you have long waiting lists. The child and adolescent mental health services are struggling to respond in a prompt and timely manner to, for example, children who are at risk of self-harm or indeed suicide. You have long waiting lists for psychologists, you have I think 20% of consultant psychiatry posts unfilled. A third of those in the posts are locums. We have a very unsatisfactory situation in the issue with regard to the issue of mental health services and provision, and looking at the figures and the spend compared to what we used to as a percentage of the health spend in the 1980s, looking at what were the actual spend now compared to 10 years ago, I think there are issues of real concern around mental health in particular. Would you agree with that? Has that crossed your desk?
It hasn't yet in this context, but I've seen it before. So I do agree. I think, again, from the past, the mental health has, in many jurisdictions, been the one which is a bit complicated, it's a bit hard to measure. You don't really know, you can't stick a thermometer in somebody's mouth and say, oh yes, we have a problem. And for all of that complexity, mental health services have lagged in other jurisdictions as well. So there's nothing you say which would be inconsistent with that at all. So yes, I think there is an issue. How you do the catch-up becomes the the issue. There's some very good work done across the water around mobilising the mental health charities and working in collaboration with the health service to change the social perspective on mental health, because what we were seeing was that a lot of the issue wasn't necessarily the clinical, it was the preclinical. If only somebody had intervened 6 months ago or a year ago, it wouldn't have needed the psychologist or the psychiatrist or the mental health services later on. And I've no reason to believe that that wouldn't be true here as well.
But there are certain objective things related to clinical provision, and we're lower than the EU average. In fact, we're at the bottom. We're lower than countries we would regard
on the
as much poor ourselves in terms of inpatient beds in psychiatry. And I mentioned the consultants. The charities can't really deal with those things.
They can set the tone and the expectation. If I can broaden the point slightly, I ran a patient organisation. Some of what we didn't take government money. Our particular niche was, we would raise money and we would fund innovation in services. I think the collaboration between the HSE and the system more broadly, and the voluntary sector and the charitable sector, I think there's a lot that can be done there to make sure that they're coherent strategies, to use the word, in mental health, cancer, the area that I used to know, or diabetes. So bringing the patient voice in much more strongly then gives you a much more implementable, fundable strategy as well. So one of the things I would be looking for is a mechanism to do that. And where I've seen it work very effectively was the mental health charities in the UK, or in England in the specific, working very well with the health service to work with the staff of often the non-mental health providers to say, look, you need to be recognising this so that we can intervene early and then reduce the burden, and as you imply, and then make sure we have the right number of consultants and psychologists and etc. in place, mental health workers in the community as well. But
finally, thank you very much for your answer. Finally, that's the last question, and thank you, Cathaoirleach. In announcing your appointment, the Health Board, the Department said that one of the priority issues for the Board would be delivering effective and safe services within the resources allocated. And you yourself rightly highlighted the issues of learning and accountability a few moments ago. I would add there's another issue of transparency. An issue that arose here this morning in private session is the question of whether the investigation into the death of a child in Hollis Street arising out of the termination of pregnancy. No, I have a particular question.
Senator, we dealt with that this morning.
No, I have a question about the investigation and whether it is a HSE investigation, because there was some doubt as to what its status is. I think I'm within my rights, Cathaoirleach, in asking whether this issue...
No, Senator, we have dealt with that issue this morning.
Sorry, Cathaoirleach, we dealt with a letter. I'm not talking about the content of the letter. I have a question to ask about an issue of public concern, and that is the investigation into a particular death at Hollis Street, which is of considerable public concern, and there has been a lot of talk about it in the media. And I want to ask you, Mr. Dolan,
Senator,
as the chairperson...
Senator, you cannot ask a specific question to the new chair of the HSE. I am ruling that question out of order.
Why is that out of order? If it's okay for me to ask about mental health services and whether they've crossed these desks, am I not entitled, Cathaoirleach, to ask whether this issue has come up so far for the Board, whether he has a particular understanding of whether the investigation is a HSE investigation?
No, I'm ruling that question out of order. I'm now going to move on to our next
I would suggest, Cathaoirleach, that you were really fettering the business of this committee if a very obvious issue of public concern can't be raised.
Deputy
already
Murphy.
got 5 minutes.
Thank you.
Welcome to the vote, and tá súlagum go mbeidh tá agat ar tá that. So I suppose a lot of the topics I wanted to cover have been covered already by my colleagues. Just a couple of things, please, Mr. Devan. The additional member, when will that new person be appointed?
In process at the moment, it's a departmental process. It's not a HSE appointment, it's a ministerial appointment, but my understanding is it's in process, and as soon as they find the right person, that person will be appointed.
Okay, so,
it's happening now.
okay, and,
Clinical.
oh yeah, I was just going to say what section, what criteria, so a clinical person, okay. And I was going to ask you to elaborate more on the public trust and confidence, but you covered that, fair play to you, with Deputy Kelly. Can I just ask you, Mr. Devan, the Sláinte care, do you fully believe that this is achievable? I suppose it has been accused of being aspirational and over-ambitious, and do you fully believe that it is implementable?
Yes, nothing wrong with being aspirational. I think if we're sitting here in 2 years' time and we've done 30% of it, we'll be saying that's great. And now, what's the next 30%? And I'm sure the vision will be getting more ambitious as we go on. So absolutely aspiration. But if we can get to a place where we have data-driven, integrated care, place-based, with the right levels of access, that's a fantastic place to be. And I'm one of the people who sort of you aim high, and let's get as close as possible, and then we can worry about the last 5% another day.
Okay, thank you.
Thank you.
Thank you,
Everything else has been covered, Chair, thank you.
Thank you very much. Now, Senator Burke.
Thank you very much. Thank you for your presentation. I have a number of specific questions that I want to ask, and it's about what has occurred over the last 4 to 5 years and how you see it going forward from now. And it's about employment in the HSE. The number of people employed in the HSE has gone up by 15,954 people since December 2014. That's a 15.48% increase. And my concern is about employing that increase of staff in any organisation. You would imagine that there would have been some kind of a strategy about what needed to be prioritised and what needed to be, planned for, but maybe looking at funding and seeing how we can do it into the future. The one concern that I have is the increase in managerial and administration staff. So there's an increase of 15% overall in the entire HSE staffing levels in 4 years and 3 months. The increase in administration management is 24%. It's gone up from 15,112 to 18,751. So that's an increase of 3,639 in 4 years and 3 months, 24% increase. Whereas the increase in frontline staff in nursing and in that area is 11%. Now that to me sounds like that there isn't a strategy. And I don't understand why there has to be an increase of 24% in 4 years and 3 months of administration and management. And I'm just wondering, is the board now going to set a strategy about looking at the whole issue of employment in the HSE? Where do we have a surplus? Where we have people, excess numbers, and where do we have a shortage? And that there's a clear, not just you see everyone who seems, and it appears that whoever shouted the loudest seemed to have got the staff. And I'm just a bit concerned. And if you look at that 15,000 extra, 16,000 extra staff, 15,954, rough estimate, it's 650 million a year.
Yeah.
And that's not going to disappear in the morning, that's going to be ongoing into the future.
Yeah.
So I'm just wondering, what is going to be the board's role in setting this, in setting targets, in setting achievements, and that's one area. The second issue that I have with the HSE is about no one wants to take responsibility for decisions. And I had an incident where a particular issue arose in a particular HSE facility. So the person who was in charge of the incident reported to the person who was overall manager. And the overall manager felt that they had to go way up along the line in the HSE, nearly all the way to the top, for what was a situation that was well under control.
Yeah.
But about 3 or 4 other people from an administration side, got involved in decisions being made on a medical side. And it just doesn't make sense to me that no one wants to take, even though the person who is the overall manager of the particular unit is in charge, they felt that they didn't have the capacity to oversee the incident that was, or the process that was ongoing. And that sounded to me the big problem within the HSE, that the decision-making process seems to be, no one seems to be able to make a decision that must go up and down the line all the time. And therefore, it's causing huge delays and frustrations then in relation to decisions being made. And I was just wondering, how do you focus on trying to change that type of approach to dealing with issues?
Thank you. So yes, we will be wanting to understand, the people strategy, then, the numbers, the recruitment, recruit people you can afford, not people you can't afford, recruit people you need, not people who may, that you might not need, or maybe there's another way of doing it. So we will absolutely be saying, okay, do we have the right people strategy here for the HSE? Again, from the past, there's always a temptation of saying, I need to do this, therefore I need another body, where actually it might be, can you ask somebody else to do it because this thing is no longer as necessary. So we will be asking the executive to say, what is our overall people strategy to make sure we have the right skills, the right people, the right pipeline, because workforce is a major issue in most jurisdictions. And the roles are changing so quickly and the specialisms are changing so quickly that even catching up is difficult. I hear your example around accountability. We have to create an environment where your unit manager feels that they own the whole problem and they can make the right decision, that they have the support behind them, they can access the expertise if they need to, but they don't need 15 other people meeting and discussing, and that and that's often what patients want. They want somebody to say, look, I'll take this on, and people respect that. I think we have to give people that confidence that they will be supported to make the right decisions. And it's back to the learning thing around safety. In one example, we hear time and time again across all health systems that a complaint comes in not because people are trying to complain, they're just saying, I want to be heard, I want somebody to listen, and I want to make it better for the next person to experience. So a lot of that comes down to individual and accountability or empowerment, to use the cliche, as well. The two things go together, and then we support people to make the right decisions. And on the very odd occasion, that something goes wrong, it's not about blame, it's about learning again, and so that it's less likely to happen the next time. So as a cultural intervention, I think there is something there.
Mr. Devan,
just on the 24% rise in administration management, I mean,
I think I'd need to look into the numbers, to be honest, but we have to make sure, if it's around a role which is around the integration of care between primary and acute, and that person is non-clinical and they're classed as a manager, then that's still a good investment. If it were around shifting the focus away from the front line and disempowering people in the front line because you have somebody else, as in your example, looking over your shoulder, then that sounds like less of a good thing. So I think we need to get into that in the specifics and the detail, but your caution about the overall rise in numbers and shift in the ratio, I think that's a point well made.
Thank you very much, Senator. Just before I bring in Senator Dolan and finally Deputy O'Connell for their one question, could I ask Mr. Devan, will you be looking for specific funding in the next budget for the implementation of Sláintecare for specific projects? And just one comment, having looked at the Sláintecare process, one of the elements that's absolutely essential is ICT, developing an individual health identifier and an electronic record so that you can get real-time data and follow patients as they flow through the system. So you might just comment on that. And finally, in relation to the filling of vacancies, as you know, there are up to 500 consultant vacancies at the moment, but vacancies in general, the complexity of filling a post is so onerous. For instance, to hire a mental health nurse, you have to go through 25 steps. If there's any blockage in any one of those steps, the appointment is delayed. So perhaps you might just comment on how you'll address the filling of existing vacancies in the HSE.
Thank you. Some of the Sláintecare activity is already funded. It's within the envelope. There will be other things within and outside the HSE where absolutely, of course, we'll be saying, look, if we want to do this, that's extra funding because of the funding isn't there and when it can't take it away. So that debate will, I'm sure, continue. Absolutely take your point on IT and data. When I was back in my Macmillan days, and yeah, we were big for a charity but small compared with the health service, but I was always saying the single best £1 million we ever spent was on data because we understood the cancer patient far better when we were able to talk to them, link their NHS number with their with the cancer registries, with research that we did as well. So absolutely, patient identified, that whole thing. What we can do now and in the future with data really will help the patient journey because we'll understand the human, not just the condition. Sorry, I missed just the very last bit.
In relation to filling vacancies.
Oh, vacancies. Look, I'm an engineer. I don't like 25-step processes. If a 3-step process will do. So I think we need to make it easy to do. We need to make sure that we have the workforce strategy in place, that we have the pool of young people coming into the careers as well. So yes, we will be looking at all of that as part of this HR strategy. Thank you.
Now, Senator Dolan.
Margaret Cahirlock, and to honour your request or requirement to have one question, which I will do. As a prelude to that, I just want to pick up on some of the things that you said, and first of all, to wish you the very best.
Thank you.
And Deputy Alan Kelly said, sorry for your troubles. Well, they're all our troubles. If what you're at doesn't work, it's everybody's trouble, and particularly people who need the health services. That's the bottom line of it. You talked about clinical governance, making it great. What about social care governance? Yeah. To continue to improve health outcomes for the public, the HSE of the future, giving staff the space to move to having space rather than as distinct from just coping with demand. We can't spend money we don't have. Charities can set the tone and expectation. You did that in reply to one of the questions there. You talked about collaboration between the HSE and voluntary charitable sector. A lot can be done here. Bringing the patient in strongly. I'd be looking for a mechanism to do that. I think I'm quoting you fairly decently. And then in regard to some of those comments were made following up from Senator Mullen and the mental health sectors, safe services within the budget. And just when you were talking about Macmillan there, the best spend, the $1 million that we spent was about data and understanding the needs of the patient. There's a whole range of chronic conditions, right? We've dealt here with 2 weeks ago we had the new Chief Executive, Paul Reid, in, and he brought with him the memo that he had issued on the 14th of June to his staff. Very simple. Hold the line on the budget. Sacrosanct. And we have to build up our trust, the trust and confidence of our funders. I'm thinking about the trust and confidence that the people who right now need the services, and all of us will one day. We need to have that assurance. You have governance quandaries around these things, and that's what I'm coming to. You're not the provider. You're the head of the governance structure that is there to provide the services. I'm trying to pick between the two of them and not unnecessarily drag into what are you doing for this and what are you doing for that. Being provider and being commissioner. We had a system in the early noughties, the ERHA, which was the commissioner and the boards, the health boards were the providers. It was thought that that wasn't necessary. The Convention on the Rights of People with Disabilities, which includes the whole mental health area, has now been agreed to be implemented by Ireland. What reflections in terms of governance? Urgent versus critical. That's sort of the political conundrum. How are I'm not against strong lobbies, but our bodies work because we have balance between different elements of them, if we have, right? So how is there balance and an appreciation and a weighting between the strong, established, powerful, and then the areas that need advocacy and support? Where is the health? And you dipped into this when you're talking about mental health, the organisations or groups that can be of assistance outside of the health area, where you prefer to be starting. Governance that's beyond regulatory compliance. That's a medley, no more, no less. But I just bring it back. How do you, as the chair and your board, put manners on all those competing pressures, tensions, and lack of pressures in some places? And right now, the edict in relation to hold the budget, I hear that saying to people with disabilities, chronic illnesses, and anyone and everyone, we will wait while one service provider earns the respect of other public bodies. And I can't find that acceptable. Shinna Wilger, Margaret, thanks.
Very short question, Senator.
Indeed it was.
Thank you. Mr. Devan.
And
Discuss.
And it's a very good challenge. You're absolutely right to say, what about the people who don't have a voice, or people who are not heard? And I think, again, in how the HSE more broadly, but we as a board engage, we need to be very alive to that. The example people traditionally talk about across the health world is the power of the acute hospital at the expense of the community, or the expense of the power of the physical health lobby rather than the mental health lobby, and so on. And I think we need to be acutely aware of that. One of the solutions, of course, is that many of the things one needs to do are common. If you'll forgive me another example from my past, one of the things which worked very effectively in my Macmillan days was establishing a group of charities. There were 10 charities involved, covering multiple conditions. Because, of course, what was happening was every time we talked to the department and say, we want early diagnosis for cancer, they would say, well, we can't give it to you for cancer. If we give it to you, we have to give it to everyone, and you would be discriminating. When we went in as 10 organisations and said, there's a common theme about early diagnosis, whether it's diabetes, mental health, MS, cancer, whatever, then people paid attention, because partly you could get your head around the problem and said, look, okay, let's focus on early diagnosis across all conditions. And then we came in behind that as what was known as the Richmond Group of Charities. So there are ways of doing it where if you leave your tribal hat out, and I tried very hard not to be seen as a cancer chief executive, but a health chief exec, and I know my colleague in British Heart Foundation did the same thing, and my colleague in the Neurological Alliance did the same thing. So we all tried to say, yes, of course, we have to fight for our constituency, but actually, if we work collaboratively, we're much more likely to be heard. So that's one answer. The question on respecting the budget, we do have to respect the budget. We cannot spend money that has not been allocated by the government and by the Oireachtas, and we shouldn't be doing that. What we should be doing is making sure we spend that as effectively as possible. The settlement between last year and this year, was good. Obviously we will travel optimistically about the settlement for next year, but we want the credibility of saying, you gave us more money, we spent that money brilliantly, we didn't spend the money you didn't give us, and then we'll have the next conversation about, now what we'd really like you to fund is this, this and this as well, whether it's in sláinte care or it's in a shortage of mental health clinical staff or whatever. So we have to, what we can't do is surprise the department and the government and say, well, I know you gave us this, but actually we went off and we spent more than that. Realising we're coming off a graph which is going up anyway. So that's around us having the financial grip, which will give you confidence that if something is funded, it will be spent well, and the money we don't have won't be spent, which will then allow you to say, actually, we want to give these people more because they did a good job with the money we gave them. So, and I think the experience of last year, is that we shouldn't be in a position of coming up with a supplementary where the gap is bigger than you would see in some jurisdictions with much larger budgets and much larger populations. Not just the percentage gap, but the absolute gap. So I think we have a job to do, and we have to do it in a way which means we will not do anything which damages the fundamental interests or the interests of the patient or the service user. That's our challenge.
Thank you very much, Mr. Dolan, and I'm sure that satisfies your questions, Senator Dolan. We now move to Deputy O'Connell, but I think Deputy O'Connell is willing to
be as quick as possible.
Be concise.
Yes, the same as the previous contributors. Thank you, Chair, and you're very welcome, Sir. It's nice to have a Sir in. It'll be the first and last time. Just for this morning.
Please.
I'm happy, I think, about the re-establishment of the board. I suppose my only concerns come from another layer being in place. And for the public out there, there's a narrative, true or not, whether the HSE is layer upon layer of administration, and to reference Senator Burke's comments, and that then manifests itself as this imbalance in recruitment, which feeds into the same narrative. While I wish you the very, very best of luck, I think we all await the, I suppose, effective performance, the effective accountability, and I would be deeply suspicious of this need to have a conversation with somebody approach to underperformance. It depends, I suppose, on the style of conversation. But based on, I do wish you the very, very best, but there is definitely that narrative out there that it's oversubscribed with admin. I assume you're a chemical engineer, is it, by background? Yes, of course, you're obsessed with cutting out steps and processes, so I look forward to that being reflected in the health service. Core to sláinte care, which many of us sat on, was the access to health care with the ability, based on your need rather than ability to pay. And we saw so much evidence of the drag there and inequality in the service. So that really is core to what has to be addressed. I'm assuming you worked in the NHS during the Agenda for Change. Were you in at that?
I wasn't.
Or were you not at that point?
After that.
It was after that. But in terms of, I worked in the NHS myself. I was just qualifying at the time as a pharmacist in the south of England, and the Agenda for Change was happening at the time. I qualified. Now I know it had its problems, obviously, and didn't completely work out, but I do believe there are learnings from Agenda for Change that can be applied to the system here. Again, so the benefits of coming late to the table is doing things correctly and learning from other jurisdictions' experience. In terms of, core to the health service is improving the patient outcome. That's the whole point. And I do believe you have to focus on the people and culture aspect, or HR, or industrial relations, or whatever you want to call it. That it's it's very difficult in the health service now, where you have things like recruitment embargoes or moratorium being put in, and it being a blunt instrument. But the key is if you stop recruiting consultants and you have the support staff, wandering around with no direction, it's not a very effective way. It might cut money off the budget this week, but in terms of long-term impacts, it can have a negative effect. So I do think the approach we've had to cutting pay by imposing recruitment embargoes is just a very, it's I suppose, ignorant tool to get the money down. In terms of finance, and it's a constant issue in health, and you referenced the graph is going up anyway, and I think that's really important, that demand and demographics will always push the graph up, definitely in the short term, until the fruits of improving health benefits pay it back at the end of the life cycle. But we have a huge issue with the cost of drugs, the cost of orphan drugs, and the cost of, I suppose, pressures, and to reference Senator Dolan's comments, those that shout the loudest getting the most. And it's a huge concern for me, where we have a very, very robust system of authorising drugs, but sometimes due to political pressures or those that have the loudest voice, that exemptions are made. But over somewhere else, there is somebody who has no voice and who requires the medication or whatever treatment. And I really do believe that key to the success is the ring fencing or some control on drug spend on an annual basis. When the money's gone, the money's gone. Obviously, you have to balance that with pharma knowing how much money's in the basket to start with. In terms, hold on, I'm only 4 minutes in now. I will be very quick.
Our Minister is waiting.
I'm sure there's 10-minute slots, Chair. And,
no. It wasn't, no. 5.
So,
for answers as well.
In terms of contingency then, last year we had the termination of pregnancy. Hopefully we've free contraception coming down. But they should be, sort of once-off payments on the balance sheet. Just finally, Macmillan and your history there, I have a huge issue or concern with privatisation of certain segments of our health service, our primary care centres. I'm just wondering, I know your background in that, but do you see it as beneficial to a health service, or are you not familiar enough with our service yet, to think that, or do you believe that having charitable organisations or private companies managing certain sectors, do you believe that's the way forward, or do you believe they just have a role? I suppose in the NHS it's a public service, and there was no private when I was in it. There's a move now to private. It's the mindset really I'm concerned about, rather than...
No,
Thank you, Deputy.
Thank you.
I'm a bit like my response to Deputy O'Reilly. I'm a public sector, public service supporter and fan, and I think the private sector has a role to play, but I wouldn't want, if you take the American model, which is much more, it does not deliver the health outcomes. It's vastly more expensive, and life expectancy is less. So why would you want to implement that? Just to reassure you on the layers question about is this a board above, I think one of the things we will be looking at relatively soon is is this subsidiarity question, it's how do we get accountability as close to the front line as possible, it's Deputy Durkan's comment about how do we support individuals, it's all of that. The remoteness question, we have to make sure that the HSE is not some small body in Dr. Stephen's Hospital, or it's some remote behemoth sitting over the people in the HSE who actually do the work. So I think that is really important. But it's not a structural problem. It's a communication, transparency, motivation, vision problem as well. And your comment on pharmaceuticals, I think my understanding is there's a big push on biosimilars at the moment, which will address part of that, and keeping control of the drugs budget. but of course providing them when they're needed is a big challenge. But in the healthcare system, we have more older people, living longer with more conditions, with improving treatment, which is more expensive. The number of drivers of health inflation built into that, which is a problem of success, it's very real. I don't think health systems will ever be cheaper because of that driver, but they have to be more effective. They have to be more prevention-based, community-based, early intervention-based. And if we can do that, then we will have the space to be able to cope with the acute and the chronic and the urgent and the unmet need as well. But that's the complexity.
Best luck.
Much, Mr. Devane. So that concludes the business of our meeting this morning. I'd like to thank you very much for coming in, and for Jim O'Sullivan coming as well. We undoubtedly will be talking again over the next few years. So thank you very much for your input. So as there's no other business at the moment, this committee will now adjourn until 2:15 tomorrow, when we will meet with Dr. Gabriel Scally on his second report on cervical check.